So today we are taking class on pulp protection. As you know, last class I took about various conditions involved in the infection of the pulp, how the pulp tissue get involved with caries, various routes of infections to the pulp and leading to root canal therapy. So today I'm going to take about the class on how to protect the pulp to get to actually protect from infections. Okay. So outline, it includes pulp irritants, protection in shallow and moderate cavities, pulp protection in deep cavities, indirect pulp capping and direct pulp capping, two types, and material used for pulp protection and new materials and methods to protect pulp. In this chapter, anyways, we are speaking about the pulp protection. Some are the new advancements and conditions are there so that we can take precautionary measures to protect the pulp. Okay. Next. Okay, dental pulp is a soft connective tissue of mesenchymal origin present within the pulp chamber and root canals of the teeth. It is not considered an external tissue, yet its exposure to external stimuli is uncleansing due to several factors that make the pulp extremely sensitive to environment outside. So this is a flowchart what I made. It depends on the pulp irritants, which mainly cause bacterial irritants and traumatic. What bacterial may be most common cause for pulp irritation. You know that when caries ingress is there, the patient actually, when he comes to OPD, he don't know that he comes when pain comes. When pain starts, then he visits the dentist. Till then he will not visit. That is a common thing in our this one. So when he comes, he tells that I have a light sensitivity. When I eat, it causes sensitivity. When I drink water, it causes sensitivity. And according to that one only, we'll tell the patient that you have taken so long time to come to dentist, and it has been progressed more towards the pulp, and we have to go for root canal therapy. This is a condition what we tell initially. Okay, when we go for an IO investigations like IOP, we will take OPG, whatever things investigations we will do. When we do it, there are certain chances to protect the pulp before the root canal therapy, so that we can protect the pulp. Except from the root canal therapy, we can protect the pulp. So caries are one of the things we can see. As it is shown in the diagram, you can see that there are certain ingress of caries towards the pulp tissue. Okay, second one is periodontal pocket and abscess. Definitely, periodontal problem is one of the condition where the perio-endo relation starts and the patient starts with pain. That is one of the condition where you have to look after for the periodontal problems. Okay, next comes traumatic. First one is acute trauma and second one is chronic trauma. Acute trauma includes tooth fracture, luxation, avulsion, etc. And the chronic trauma includes parafunctional habits and bruxism. Bruxism is one of the condition where anatomical disturbances mainly lead to certain occlusal problems, and that may lead to fracture, etc., etc. I hope you are understanding the things, because if I am fast, tell me to slow it down. Otherwise, if it's okay, it's no problem. I'll continue. Okay. Next one is iatrogenic during tooth preparation. That is iatrogenic. We don't know the cause and reason. During tooth preparation, heat production during cutting procedures. Definitely. One thing I want to tell before I'm going to start. One patient came to me in my clinic where I started drilling the tooth. The outer section, that is outside enamel area, is fine, superb. But when I started preparation, slowly it's the black discoloration inside, apart from enamel, inside it has started. Where it has started from? Whether from the interdental area, whether from the gingival tissue, yes, maybe there are ingress of as a roots of transmission of pulpal bacterial, we don't know that one. So it started, and I told the patient, no sir, we have to go for root canal therapy, then you go for a crown, either from this one restoration. That is one thing. One main thing, it may be a normal tooth, and we patient don't want any type of treatment, but still he wants cap, the crowns, what we tell as crowns, the bridges. At that time we start cutting the tooth structure. When we cut the tooth structure, the heat production may lead to sensitivity of tooth, because while preparing a tooth for your crown preparation, definitely you have to go with certain length and dimensions. According to that one, it depends. Okay, it also depends on the rotation per minute, how much rotations you go for a aorta. That is also counts, which mainly leads to heat production. Okay, coming to the slides, it's revolutions per minute, RMP, that is RPM. RPM. In RPM increases, heat production increases, speed must not exceed 3000 rotations per minute. Pressure, it is directly proportional to the heat generated. And surface area of contact, the more the contact between the tooth structure and revolving tool, the more is the heat generated. Excessive heat generation leads to change in dentine color due to vascular stasis and hemorrhage in the subodontoblastic flexus present in the pulp tissue. Okay. Next comes pressure exerted, or how the pressure creates the pain. Pressure of hand or rotary instruments, nuclear aspiration of odontoblasts or nerve endings from pulp tissue into the dentinal tubules disturb odontoblast metabolism, leading to their complete degeneration and disintegration. What is this slide indicates? Yes, definitely. When you started your crown preparation, cavity preparation, you are doing the cavity preparation properly. It is done. When your cavity preparation needs the depth of your floor, definitely some patients will have a sensitivity. Why is that sensitivity? That is because of your tubules, dentinal tubules, which mainly leads to sensitivity, where the water-filled dentinal tubules get more sensitive, and the direct shock will be to the pulp only. Okay, why we go for air spray in the aerator? Why? Because when we do preparations in your preclinicals, definitely you will not have an air or a water dispensing tool. Why means, in that you don't have any type of sensitivity, because it's dummy thing what you are doing. But in live patient, when you started, the dentinal tubules have sensitive, and they get sensitized when you cut a tooth structure. Got it? Next is orthodontic movement. What is orthodontic movement? This is a simple thing, but I will explain you in more easy way. When you start with the ortho treatment, imagine how the pain comes, how the odontoblast acts, how the odontoclast acts. When you apply a braces, the adjacent bone present start dissolving. Dissolving means odontoclastic activity starts, your bone start losing its density as you are moving your tooth with a band of wires. Got it? When you pull it, definitely the adjacent bone gets disturbed or dissolved due to odontoclastic activity. Got it? The adjacent side, where it is moving, odontoclastic activity, both sides it starts. But once the retention is formed, like your ortho treatment is done, we go for a permanent retention. We go for certain static wire presentation. That is, static wire means we place the wires without any movements. In that cases, what happens? Orthoblastic activity starts. Odontoblastic means the generation of the cells. Both the sides at odontoblastic activity starts, and the new cells formation is there. Your calcium levels are increased, then the tooth holds there. So it's the concept of orthodontic treatment. Periodontal and periapical curettage. Yes, this concept, when you go for periodontal or periapical curettage, we remove the adjacent. Why we go for a root curettage? Why? Because when we go for a root curettage, definitely the infections present in the root areas, both adjacent, mesiobuccal and distobuccal. Same thing, we remove it completely and we go for a ZOE pack or whatever things the periodontist does, mainly to pack the things so that the approximation of gingiva towards the tooth structure is good. Got it? Next comes your use of chemicals. What is use of chemicals? Temporary and permanent filling bases, liners, and use of alcohol and other leads to pulp injury due to cytotoxic acidity, heat formed and marginal leakage. There is not much to make you understand in this slide, so you know that one as a sentence is straightforward. Next comes idiopathic. Why the idiopathic thing? What happens? Aging. Yes, age of a patient is also one of the important factor where you have to go for maintenance, what we tell as maintenance. Visit the dentist every 3 months, 6 months oftenly, so that you can be diagnosed or with the caries or the any oral problems. Okay, it includes resorption, which are of two types: internal resorption and external resorption. Because of these various irritants, pulp needs protection. I think most of you think that sir, we brush twice a day but still we have a caries. How we should do that one? How should we protect our teeth without any this one? I use such a beautiful paste, such a branded paste I use, but what type of food do you eat? What type of junk food you eat? Whether you eat and brush in the night, that is a thing, but the citric acid what you are taking, which mainly produces acid formation. That acid formation mainly, what happens? The acid production may lead to caries, ingress of caries. The enamel layer will be gone. So don't go for more junk foods, that because they are not healthy to your tooth structure or oral cavity. Primary factors of good restorative dentistry includes preservation of health of dental pulp, non-irritating restorative materials with suitable physical characteristics or properties, effective barrier to protect pulp from harmful effect of present filling materials. Got it? Pulp protection, I am going to coming to next slide. Pulp protection, that is moderate carious lesions for deep carious lesions. For moderate carious lesions, caries penetrate the enamel and dentine, and not to an extent of that is more deep it will go. Next comes liner is applied to cover the axial and the pulpal walls. Definitely. What is the use of liners and bases? I told you in the before class only. Before taking this, I explained you about why we use liners and bases. Definitely, it will protect the pulp tissue by going deep, and when you drink hot or cold food, you will not have sensitivity to your pulp tissue. Okay, base material zinc phosphate, zinc oxide, eugenol, glass ionomer, and polycarbonate is placed over the liner. Definitely, you know that one. Why liner is applied, why is base is applied. Base always have a certain thickness so that it can protect the pulp. Got it? Next comes deep carious lesions. Definitely conventional methods are there, recent methods are there, indirect pulp capping is there, direct pulp capping is there. We can go for this one. Okay, next slide comes to conventional methods. What are the conventional methods? Direct pulp capping. Direct pulp capping is placing a biocompatible material over the exposed pulp to maintain vitality and promote healing. Why we go for direct pulp capping? Mainly to maintain the vitality of the remaining pulp tissue, to prevent root canal treatment, and to help conserve tooth structure. What are the indications? What are the indications means? Recent small mechanical exposure of pulp during or more than less than 24 hours, tooth preparation and traumatic injury. non or minimal bleeding of the exposed tissue or a site. Contraindications: wide pulp exposure, we can't go because we have to go for root canal therapy. Pre-operative history of spontaneous pain, presence of bleeding at exposure site. Radiograph doesn't show any pulp pathology. Yes, when we don't show when the pulp radiograph doesn't show any type of pulp pathology, then it's an indicative that we can't go for pulp protection. Definitely in certain fracture cases also we don't go for protection of the pulp, because at that time the pulp is exposed. If we don't go for root canal therapy also, after certain age or a period of time, the tooth starts discoloring because of the loss of periodontal tissue, periodontal tear, PDL ligament widening, PDL death, everything is there. So at that time we'll go for root canal therapy and go for a prosthesis. What are the clinical procedures what we go through? Administer local anesthesia, isolate the tooth with rubber dam, as you know that one. When vital and healthy pulp is exposed, check fresh bleeding. Next comes apply calcium hydroxide over the exposed area, you know that one. Dry it with a cotton pallet and clean the area with saline cotton. Next comes the give interim restoration, that is intermediate restorative material such as zinc oxide eugenol for 6 to 8 weeks. Definitely when a patient comes with the sensitivity of the tooth, definitely we will go for pulp protection by placing the whatever calcium hydroxide. After that one you go for a zinc oxide eugenol paste for 6 to 8 weeks. Then we will call the patient and we will go for permanent restoration. Okay, remove the cement to insert the exposure site, inspect the exposure site and how it is formed. In secondary dent, if secondary dentin formation takes place over the exposed site, restore the tooth permanently with the protective cement base and restorative material. Then, if not, pulpotomy or the root canal therapy, that is what we call as next level of treatment, should be done to the patient. So indirect pulp capping. In indirect pulp capping, all caries are removed except the ones that lie adjacent to the pulp. Caries near the pulp is left in the place to prevent the pulp exposure, and the preparation is enclosed with by a compatible material. Definitely the procedure is same. Indications: deep carious lesions near the pulp tissue but not involving it, no mobility of the tooth, no history of spontaneous toothache, no tenderness or precautions to percussion. No, there will be no tender on percussion, as there is no edema at the periapical area, no radiographic evidence of pulp pathology, no root resorption or radicular disease should be present radiographically. Clinical procedure, it includes the same procedure as an indirect pulp capping, except that the pulp is not exposed, a thin layer of dentin and some amount of caries is left to avoid exposure. Factors affecting pulp capping success, that is age of the patient. Due to vascularity of the pulp, young patients have greater potential for success than other older ones. The type of exposure mechanically is different. Mechanically and done a pulpal exposure, etc. Size of the exposure. In large exposures, it is difficult to control the hemorrhage and tissue, that is what is seepage. Small pinpoint exposures are easy to manage and have a greater potential for success. Larger, we can't do it. History of pain. Previously, pain has not occurred in the tooth. The potential for success is more. Recent methods include laser in pulp capping. So many lasers techniques are there. We have what we are implemented in the protection of the pulp. It's very important to go through this one. So laser therapy is one of the therapy where we go for protection. Stimulus mineralization is dental pulp. Also, I'll continue the class next time, because more preparing is not so this one. So in the next class I will explain you about the important techniques and this one, including your recent advancements also. Thank you.